Good afternoon to all of you. Welcome to our today's webinar. I am Dmitriak Oksana, and I support and coordinate technical working group for MHPSS. So we are here today for another webinar from the series of webinars and supervisions for MHPSS in the context of COVID-19 pandemic. We are now speaking about the general methodology for monitoring and evaluation. The webinar is going to be led by Sarah Harrison, who is a technical advisor for psychological support.
Is in multiple directions. So it's accountability to the people that we claim to be assisting. So our populations of concern, to use UNHCR terminology, or beneficiaries, or rights holders, as sometimes they're called by some NGOs. So anybody that we are assisting in our programs, we are accountable to them in terms of what we say we're going to do, the types of services provided, and the quality of those services provided. And also from a compliance and accountability perspective to the people that are giving our agencies money, whether it's an institutional donor like a government or a development agency, or even if it's just funds from the public in terms of taxpayer funds that are being spent on humanitarian programs. It's also monitoring evaluation provides us with the opportunity for feedback from stakeholders, and the stakeholders are usually the people that we are assisting, so the beneficiaries or the populations of concern. But stakeholders could also be your own staff if you're working on capacity building initiatives or trainings, for example. And it's part of the feedback mechanism and the dialogue that you should be having with communities and with families and individuals you assist, but also with the staff and volunteers that, in which you work. And then lastly, it's an opportunity to promote and celebrate our work. Particularly if a program or an intervention has been really successful and has made a demonstrated positive impact and positive change on the lives of people living in emergency settings, then it should be something that we celebrate and we share it across agencies, as well as kind of like a recommended way forward or like a good practice. So what is monitoring and evaluation? So monitoring is the systematic gathering of information that assesses progress over time. So monitoring is something that you should be doing within your organizations on a regular basis. And usually a regular basis means something like a weekly activity report, or it could be a daily report based upon numbers of people receiving services at a community center, or at a healthcare facility where you might be providing mental health care. And it can also come through your monthly reports as well. So your kind of daily, weekly and monthly activities that are assessing how well your program is progressing against your objectives and against the activities and the deliverables that you said you were going to do in the project. For example, numbers of people trained. Are you on track for your target? Or numbers of people reached through a healthcare service, a community mental health service, for example. And you can track how many people are enrolled in your activities and whether you are on track to meet your targets. And then the evaluation happens at specific information points and at specific times to determine if actions have been taken. So in an ideal situation, you would have an evaluation at the beginning of a project, something often referred to as a baseline assessment or a baseline evaluation, or a very in-depth assessment. And then you can have in long-term projects, so in projects that last more than a year, you can have a mid-term evaluation. That's something that happens midway through the project to make sure you're on track. And then you can have what's called an end of project evaluation or an impact evaluation. And evaluation tends to be much more difficult to do in terms of much more detailed. It's sometimes done by external consultants or an external evaluation organization that's asked to come in, maybe by your donor organization, to just evaluate your projects. And this is particularly the case if you have large projects or a large portfolio with one donor that's looking at building up mental health and psychosocial support. So monitoring is ongoing, easier to monitor, easier to do, because it's part of your daily, weekly, monthly reporting activities. And then your evaluation is harder to do, and your evaluation is looking much more at the impact level. So the overall changes over time and the outcome level as well. And I will go into those differences in a minute. So as you can see on this chart, they're interlocking initiatives. You can't just have monitoring and you can't just have evaluation. The monitoring data and that regular collection is important to be able to actually do your evaluations as well. So that's why you can see it's an interlocking Venn diagram. Okay, so the underlying core principles, which are written in the guidelines, and these are the 2007 guidelines. These principles also apply in monitoring and evaluation. So, for example, with regards to the human rights and equity of all affected persons, that means that when you do your monitoring and evaluation, you need to be able to ensure that you are reaching all the beneficiaries that you are assisting, for example, and making sure that formats for reporting, for providing feedback are accessible to those populations, and any involvement of beneficiaries in your feedback or in your monitoring reports and your evaluations is by consent. So particularly if we're working with people, for example, with severe mental health disorders, that means that we are presenting our questionnaires to them or our surveys to them in not only a language they understand, but a format they understand. So it might be that you need to explain in more detail a survey content to somebody to make sure that they understand it, particularly if you're working with people, for example, with dementia or people with a severe mental health disorder like psychosis, for example. So it's making sure that monitoring and evaluation formats and documents are in a disability-friendly format and content, so they can be understood by people, and any participation of the local affected population in monitoring evaluation is by consent as well. The do no harm is also on the basis of how the material is stored. So if you're collecting sensitive information about people, and this is usually in relation to their health data, their mental health data, so any organizations providing clinical mental health services, then you have a duty of care and a duty of responsibility in how you store that data, and making sure that that data is not abused by other entities. Similarly, if people are engaged in our programs, then they should not put them at risk. So that's the do no harm principle. The building on available resources and capacities is very much ensuring that the programs and the interventions that you design are again grounded in the context in Ukraine, and that where possible they are provided by local staff and local resources that are available in the country as well. And that's the same for monitoring and evaluation. And the people that are going around collecting the data, for example, sometimes they're called enumerators in some organizations, or monitoring and evaluation officers, that, for example, they speak the local languages, that they've also been trained on how to collect the data as well. And then the integrated support systems and the multi-layered supports, these relate back to the intervention pyramid, which I think most of you are familiar with. And it's the same for monitoring and evaluation. You need to be able to monitor and evaluate the full spectrum of mental health and psychosocial support services across the pyramid of the intervention as well. Okay, here's the next slide come up. So the indicators that you can see on the screen, and they're listed there. And we have what's called one goal, which is overarching, and it is a goal is something that you look at impact level. So at the level where you're looking to do evaluations. And a goal is where you often have many programs or interventions that feed into it. So it's quite broad and quite all-encompassing as well, because it's meant to be able to cover the full spectrum of mental health and psychosocial support interventions. So the goal that we have in the framework is actually set, and it's reduce suffering and improved mental health and psychosocial well-being. So now that we have that as a big goal level, underneath it, we then have indicators that you can use to measure against that goal. And there are 6 indicators. And this is what I've extracted from the monitoring evaluation framework for you. So the first indicator is looking at functioning. And this is something that's very much used by organizations providing mental health services, because you often want to measure a patient's ability to function or a client's ability to function as a result of receiving mental health care services. Functioning is also used by agencies that are working with clients who have potentially suffered from conflict-related injuries, such as stepping on a landmine, or picking up a grenade or something that might have left them with a physical impairment or a physical disability. You look at functioning to see how well they are physically able to function, but also to see how well they are psychologically functioning as a result of their injury. The next one is subjective well-being. And this goal indicator is often used by agencies that are providing more psychosocial type programs or protection programs that have a psychosocial element. It's used a lot by child protection actors as well. And you can see that there's a suggested definition there of what we mean by well-being. The third indicator is extent of prolonged disabling distress and or presence of mental, neurological or substance use disorder or symptoms. And this is, again, for agencies providing more clinical mental health care services, either in an institution or in a prison environment or in a healthcare facility, whether that's a primary healthcare facility or a secondary level care hospital. So you're looking very much at people there that have a diagnosis and have a mental health condition or have substantial symptoms of a mental health condition. The fourth layer, or the fourth indicator, sorry, is the ability of people with mental health and psychosocial problems to cope. So this is very much looking at coping strategies and has an overlap again with kind of protection activities as well. And there are examples there of ways of coping. So communication skills, stress management, problem solving skills, conflict management or vocational skills. And that again is used by agencies that are providing probably more integrated programming where you have maybe an MHPSS and a livelihood program, for example, or an MHPSS program focusing upon youth where you want to teach them life skills and vocational skills as well. And then the last 2 indicators are very much focusing on social behavior and social connectedness. So looking very much at community and group type activities and group interactions. It's used a lot by agencies working with children and with youth because you're wanting to measure aggressive behavior in these population groups, or use of violence for something, and as well as discriminatory actions. So we also know that mental health and psychosocial support conditions are inherently stigmatized in many societies, and often people with a mental health condition are discriminated against in access to services or in ability to get jobs, for example, as well. And that's measuring the attitude of society towards people with mental health conditions and how they're supported. And then the last one is social connectedness. And this one has a strong overlap with organizations that might be working with peace building or conflict transformation type work, as well as rebuilding communities in more conflict settings or where there's been civil unrest. And you're looking at the number of connections that an individual has, in addition to looking at more group or family interventions. And the social connectedness is also important for organizations working with people with mental health problems, because it's also a lot about their reintegration back into society again, and overcoming any stigma that they might be affected from as a result of their condition. So the key thing is, as an agency, you don't need to pick all of those goal indicators. Use the goal as a standard one in your programs, but then you just need to pick one goal indicator that best reflects the types of services you are providing. And that's what you will use at the impact level, so more at evaluation level, to be able to report against at the beginning, the midpoint, and the end point of your projects. So out of those 6 goal indicators, you only need to select one. And it doesn't matter which one, they're all equally valid and equally important as well. So it's more about the fit with your particular programs and interventions. So that's at the impact level, the goal level. And then after that, we also have 5 outcomes. So outcomes are measuring changes over time, usually changes in behavior of people. For example, behavior towards people with mental health conditions, if you're looking at stigma reduction activities, but also it can be changes in behavior of your individual clients if they are healing and getting better. It can also be changes in knowledge gained. So if you're doing capacity building activities for your staff or for other government officials maybe, and it's usually something that you can measure on a quarterly basis. So bridging something between your monitoring and your evaluation times. So there are 5 outcome level indicators, and you can see that they've been split into 2 groups. The first group is the community focused outcomes on the right hand side, and there are 3 of them here. And the community focused outcomes are looking at emergency responses do not cause harm and are dignified, participatory, community owned, and are socially and culturally acceptable. And people are safe, protected, and human rights violations are addressed. And then lastly, family, community, and social structures promote the well-being and development of their members. So you're looking very much at broad programs, group interventions or family interventions, or general community level activities. And they have also, you can see in outcome 1 and outcome 2, they've also got a very strong protection and a human rights lens on them. And that relates back to the core principles of the IASC guidelines that I went through earlier, where human rights and dignity are a key part of all of the guidelines. It's like a central thread through them. So that's why they're also reflected there under the community focus outcomes. And then you can see on the left-hand side, you've got person-focused outcomes, and there are 2 of them. So communities and families support people with mental health and psychosocial problems. And then the second one is people with mental health and psychosocial problems use appropriate focused care. So for the second one, agencies are again providing the more clinical mental health care services would use that outcome indicator. And there is a difference between the person-focused outcome number 1. So communities and families support people with mental health and psychosocial problems, because it's a very, it's an outcome that's looking at your focused activities that are zooming in on the people specifically with a mental health and a psychosocial problem. So it's a particular subset of the population. Whereas outcome 3, under the community focused outcomes, is looking much more at the broader population level initiatives, looking at well-being and development of all of their members, so all members of society, irrespective of whether you have a mental health problem or not. So that's a distinct difference between those two. And the distinction comes a bit clearer when I show you now on slide 7, where you have the intervention pyramid, which I hope you're all now familiar with the 4 layers. And you can see in the boxes on the left-hand side, I have mapped out where the outcomes, the 5 outcomes, fit in relation to the intervention pyramid to help you select which outcome is most applicable to your programs or your interventions. So you can see that at the layer 1, at the bottom of the pyramid, you've got the social considerations and basic services and security. And that's where you've got those very protection, human rights focused outcomes. So community outcome 1 and 2. And then as you move to the second layer, you've got the outcome focusing on the family, community and social structures, promoting the well-being and development of all of your members. So this is very much your women's groups, your youth clubs, your child-friendly spaces or your children's clubs at school, for example, as well as anything to do with your faith-based groups and any other community level activities. And then that third layer, that focused layer, you've got the communities and families support people with mental health and psychosocial problems. So you are zooming in and you're just focusing on people with those problems. So those problems can be in relation to people that might have experienced abuse or intimate personal violence or suffered from stepping on a landmine or explosive ordnance left over from the conflict, for example. And it could also be people that have a mild mental health condition, so people that have got mild anxiety or depression as a result of the emergency or before the emergency. And it also includes people with the pre-existing problems. So, for example, a child with autism spectrum disorder or a person with epilepsy, for example. And then at the top layer, you can see you've got the specialized services and you've got people with mental health and psychosocial problems use appropriate focus care. So that's looking very much at your clinical mental health services. And it particularly uses appropriate focus care to indicate that it doesn't just have to be psychiatric care. It can also be social care services for people with mental health and psychosocial problems as well. So that's how the 5 outcomes map onto the intervention pyramid, and that will hopefully guide you on knowing which outcome to use when you're building your programs and projects. And the breakdown of the outcomes into the community focused and the person focused is actually on the back page of the monitoring and evaluation framework. It's like a table, so you can always refer to it there as well. Now, what we have done in the monitoring and evaluation framework is we've used a logical framework setup or a theory of change setup for those of you that might be more familiar with monitoring and evaluation terminology. And what I've shown you on the screen here is an example of a logical framework template, a little bit of an example, and how it relates to what's written in the monitoring and evaluation framework. So you can see at the column on the far left, you've got the goal, outcomes, and outputs. And the goal level has already been set for you in the monitoring and evaluation framework. And that goal is reduce suffering and improve mental health and psychosocial well-being. And then you've got the indicators, those 6 impact level indicators that I went through with you earlier. And you can see that's written in the second column where I've written indicators. And then you've got the means of verification. And then on the column on the far right, you've actually got the action sheets that relate to the original IASC guidelines in 2007, and you can see that which action sheets are relevant for the goal or for those particular impact level indicators. And that's chapter 5 in the monitoring and evaluation framework, and I will go through that with you shortly. The second row you can see is the outcome row, and again you have 5 outcomes that you can pick, and you just need to pick one outcome out of the 5. So one of the community focused outcomes or one that's more person focused, and it depends again on your program. And then in the document, in the framework, on pages 13 to page 25, you have a list of all of the outcome indicators. There's, I think, 37 outcome indicators, and you need to pick 2, basically. So you need to pick 2 outcome indicators and write them in your log frame. And the indicators are under each relevant outcome. So for example, outcome 1 on emergency responses do not cause harm and are dignified and participatory. That one has a list of indicators that we recommend you use, and you just need to be able to pick 2 of them and insert them into your logical frameworks. And again, in chapter 5, it links you back to the action sheets where you can see the technical content and the technical guidelines that relate to that particular programming area as well. And on the third layer, at the very bottom row, there's something called outputs, and these are sometimes referred to as activities in some logical frameworks or in some theories of change. And the output level is not included in this monitoring and evaluation framework. And it's not included because it's easier to measure. So for example, numbers of people trained would be an output level indicator, or numbers of people receiving services from the community center. And the request when we were asked to create the monitoring and evaluation framework was to be able to push the quality of M&E in relation to mental health and psychosocial support. So we were asked to really kind of push the boundaries and to make sure that agencies were better able to measure outcome and impact level, because that's where they were having most challenges. They were not reporting challenges at measuring output or activity level. So for that reason, that's not included in the framework. You can see on the third column where you've got means of verification and how will we measure change. So this is your data collection tools. So once you have your indicators, you then need to know how you're going to collect that data to report against that indicator. And the means of verification we are working on now at the moment. In fact, we've been working on it since the document was released as a field test version, like I said at the beginning. And by the end of this year, we hope to have all of the data collection tools for the impact level indicators available for agencies to use. We have both quantitative tools, which are, for example, specific surveys or questionnaires that you can use. Often these have been developed by universities or by researchers and have then been tested in humanitarian contexts. And we also have qualitative qualitative data collection tools with an explanation on how you can use them in your work to measure an indicator. And this has been a massive piece of work because all of the data collection tools, in most cases, we've had, well, in fact, in every case, we've had to get permission from the original developers or the original researchers for their tool to be used in the M&E framework and for it to be shared with agencies. And there's over 40 data collection tools that we've had to go through, and we've had to assess them in terms of inclusion and exclusion criteria. So, for example, are they freely available? Are they available in multiple languages? Have they been tested? As well as looking at more kind of scientific concepts. For example, do they meet the validity criteria? Or are their psychometric properties valid? And that's why it's taken us so long. We've had to go through about 40 data collection tools, and now we have the final set. And we're just in the last phases of getting the permissions from their developers for them to be freely used. And then what's going to happen is that we are going to include the means of verification in an updated version of the monitoring and evaluation framework, which we hope to have finalized by December this year. So in the moment, in the current version that you have, these data collection tools or the means of verification are not included for the indicators, but they will be included in the updated version, which will be released shortly. So what I'm going to do now is share with you the indicator table. And in your documents, if you have the document in front of you, it's on pages 14 and 15, and it's called Table 2 in your document. So what you have under Table 2 here, so in your document that's on pages 14 and 15, you can see the box in orange here is a listing again of the key impact indicators, so measuring the goal level. And then what you have underneath is the outcomes. So you can see here you've got outcome 1 written, and then beneath it you've got the outcome indicators, and you can see them written down here and also at the top here. So there are 8 outcome indicators for outcome 1. And then the same for outcome 2. You can see outcome 2 is written here. And then you've got a list of outcome 2 indicators written underneath. So these are indicators to help you measure that particular outcome. And then the same thing on the next page, you've then got the next 3 outcomes. So outcome 3 is written, then a list of outcome 3 indicators. Outcome 4 is at the bottom here. And then you've got outcome 5 and a list of all the indicators. And what you need to do is pick 2, you need to pick your impact level indicator to measure your goal. And then you need to pick 1 outcome out of the 5. And then after that, you need to have a look at the indicators under that outcome and then select 2 indicators that you're going to use in your programs as well. So that's the logic that we ask you to follow when using the framework. And this logic is also written, sorry, you can see on page 11 here that in the box, what we ask you to do is 1 impact indicator from the common framework, at least 1 outcome and a corresponding outcome indicator from the common framework. So some agencies go for 2 outcome indicators and some just go for 1. So you need to have 1 impact level indicator measuring against the goal and 1 outcome and then the corresponding outcome indicators as well. And you can use that table, Table 2, on pages 14 and 15 to select which outcome is relevant for you and which indicators are also relevant. And then just the last thing I want to show you is on Chapter 5. If you go on page 17, we'll just look at outcome 1 on Chapter 5. You can see that at the top line underneath, you've got a list of numbers. And these numbers here relate to your guideline numbers in your action sheets in the IASC guidelines from 2007. So you can see that you've got a list of numbers. So 3.3 or 5.1, for example, is action sheet number 3.3 in the IASC guidelines in 2007. And everything in relation to this outcome is written under those action sheets. So you can go and see the technical guidance to guide your programs and your interventions under those particular action sheets, and then you know that it's relevant and you can report it under outcome 1 in the M&E framework. So it can help you also in the way that you design and you build projects in addition to your monitoring and evaluation of those projects or programs once they're underway. And this is the same for every single outcome. So that in chapter 5, it goes through all of the outcomes one by one. And it lists the guideline action sheets, and then again gives you a list of outcomes. So I'll just show you. For outcome 1, it has a description of it on the first page, and then on the next page it lists the outcome indicators again. And that's the same for every single outcome in chapter 5. And that is basically how you navigate your way through the framework. In chapter 6, we've got the section on measuring indicators. So that's your means of verification, your data collection tools. And that is the part that's very much under development, and it's something that will be updated and will be expanded upon later on this year, and hopefully we'll have it completed for you by the end of the year. So you also have all the data collection tools to help you with your work as well. So the key thing about the framework is I know it's a very technical document, and I hope it's going to be useful. I know that it has been useful since it's been released in 2017, but it's one of those documents that you need to kind of dive into it, and particularly though that table 2, where you have all the impact level indicators and the outcome level indicators listed. To be able to apply it to your programs and to think through, how does this work in my context and with my interventions and my projects that I'm running. And the idea is that hopefully at an interagency level, if all of you are using the same kind of M&E framework or the same approach to measuring things, then at the working group level, within Ukraine and in your subnational groups as well, you can begin to compare data. Or if all agencies are providing a similar type of intervention, for example, if agencies are rolling out Problem Management Plus, for example, or you're all doing a children's clubs activities, then you can agree at the interagency level on which indicators make most sense to do that type of programming intervention across your agencies. So you can then begin to document and measure change much more at the population level, because all agencies providing, for example, children's clubs, are all measuring their intervention in the same way. And it makes it better in terms of documentation and building the evidence base for what's working in Ukraine or not working as well. And just the very last thing, at the end of the M&E framework, there's an annex, and in the annex we have examples of logical frameworks and theories of change using the M&E framework. And I've kind of copied and pasted and written out just 2 layers or 2 columns, sorry, of 2 projects that are taken from the annex section. And they are projects that are based upon what some agencies are doing, and they submitted their log frames as part of the creation of the framework as well. So these are written in the annex section, so after chapter 7 in the framework, if you want guidance on how to apply this in your work. So the annex documents start on page 35 and go through until page 41, and then you have the back page as well. So that's it from my side. I think I will stop sharing my screen now. So that's it from my side. I don't know if anybody has any questions or points for clarification that they would like to ask. If you write it in the chat function in Ukrainian, then someone will need to read it out in English, or you can say it in Ukrainian and someone can then give me the oral translation into English. I'm sorry, I don't speak Ukrainian or Russian. That's my apologies. And Natalia, thank you for your question. So You're welcome for the presentation. Thank you for the invitation as well. The question is, does the monitoring evaluation framework, is it relevant in urban settings, or is it only relevant in refugee camps? The framework's relevant in every setting and in all contexts. So the only limitation, if I can use that word, is that it needs to be an emergency setting or a humanitarian context. But that's a very wide and loose definition, because you can get countries such as Ukraine where you're in a more transitioning or reconstruction phase, and you can get refugee-based settings, for example, in Uganda, where Uganda as a country is not an emergency, but it's hosting a very large number of South Sudanese refugees. So in that case, you would use it in a refugee camp setting. But it is meant to be used in internally displaced context settings as well. So anything that fits under the understanding of an emergency. So also covering natural disasters, public health emergencies like the coronavirus pandemic, as well as your conflict and your civil unrest, and your refugee or migration settings as well. So it should be applicable in all settings, providing it fits the definition of like an emergency or a humanitarian setting. I don't know if there are any more questions for me.
We can give some time if someone is typing the question in the chat.
Yeah.
Okay, I think probably not. And I'll just continue for Sarah to understand what is going on, because you don't have the room for a translation. And I hope
okay.
We're receiving translation from Anna at the moment.
There's just one thing I could say from my side, Oksana, two things actually.
Yeah.
With regards to the support that I can provide to agencies and organizations, which I'm very happy to do. It's part of my my job, my responsibility as the co-chair at the global level. And I think it's really important for agencies to kind of go away and really have a look at that table 2 in the document, where you have those list of indicators, and to think about how to apply it to their current projects, maybe doing it as like a test, and then also to think about how they could include this information in future projects or proposals that they might be writing, or concept notes. And I'd be happy to help people think through that process, or have a call with agencies, however they want to work, either via email or on a call, to talk through how it might fit within their particular context. And maybe if your organizations also have a monitoring and evaluation officer, or a data, a person responsible for data as a data focal point, then it might be worthwhile them also being involved as well. But as Oksana said, please reach out through the email address, and then they can channel the requests to me if there are any, but I'd be happy to support. And thank you very much for the invitation to present today. And I apologize for not speaking Russian or Ukrainian.
Thank you, Sarah, for your comment as well. So if you come up with the questions later, you can reach us out at mhpss.tvg.ukraine@gmail.com. This is the email of a technical working group for MHPSS in Ukraine. And as we mentioned in the beginning, that Sarah is available for supervision, but as we want to make it in a more structured way, we would like to ask you to reach us out through the mentioned email. I can duplicate in the chat function so that we will come up with the date and time and the schedule if needed. Yes, if you have more questions or comments and you don't want to raise your voice now, please contact us via email. I think that's it from my side too. Is there anything anyone would like to add? You can add it now. Otherwise, we will close the webinar for today.
So timing is key now to promote MHPSS across different sectors and integrate really mental health further into response to humanitarian emergencies and COVID pandemic particularly, and also to integrate mental health in community level services and general health care. And I would like to say a couple of words on the initiative that we launched today. The name of the initiative is addressing MHPSS aspects of COVID pandemic. The purpose of the initiative is to support partners to adapt their programs to new challenging reality created by COVID pandemic. The initiative was prepared by MHPSS Technical Working Group Ukraine with support of Global MHPSS Reference Group, and it's based on needs reported by you actually to the working group, which are related to new circumstances that brings COVID to our life. And now I would say that we're all struggling with new reality, and probably common and well-known approach might not work anymore. During such challenging times, it's important to ensure effective MHPSS response along with maintaining essential services to the population and population both affected by the pandemic and pre-existing humanitarian crisis in eastern Ukraine. The workshops will be held online and conducted by international experts from IASC Global Reference Group on MHPSS. And among the experts, Sarah Harrison, MHPSS Technical Advisor of IFRC, co-chair of MHPSS Global Reference Group, Fami Hanna, MHPSS expert at WHO headquarters and co-chair of the Global MHPSS Group, and Anita Marini, expert within the Italian public health system and also expert on vulnerable groups. And next expert is Marcio Gagliato. You probably all know him. Marcio is Senior Humanitarian Advisor and Director of Operations of the Global MHPSS Network, MHPSS.net. And the series of learning events will cover overview of recently released MHPSS evidence-based recommendations and tools, and role of multilateral collaboration. And Fami will start with this today, a bit later, and program planning, monitoring, and evaluation, as well as inclusion of vulnerable groups during COVID pandemic into response. This is initial list actually suggested by you, but the situation evolves rapidly, and you are welcome to add new topics to the list, and we gladly will try to address those as well. And the initiative is planned till the middle of August, but again, it can be continued if needed. And the learning activities by nature will start with online webinars and followed by supervision sessions. And with this, we aim to provide our partners very practical, very targeted support. And during supervisions, we will be working with your own case studies of your agencies and practical examples from the field, trying to address particular organizations' needs. So the initiative is starting today, and with this, I would like to pass the floor to Dr. Fami Hanna. Fami, over to you, and meanwhile, we're trying to switch on your presentation.
Thank you very much, Isa, and thank you, Jarno, and thank you, colleagues, for this opportunity. As you all know, I'm not a stranger to Ukraine. In fact, during the last four years, this 6 months with COVID is the first 6 months ever that I have not visited Ukraine during which. So this webinar is a sort of mental health and psychosocial support, helping me to deal with Ukraine visit craving. So thanks thanks for the opportunity. Alisa, how much time do I have?
Fami, I think we have up to 50 minutes, but we can be flexible.
Okay, I will try to finish in around 15 minutes, so we can have a discussion around questions, and I tried to put a challenge for myself where I talk about everything that happened on MHPSS globally in only 3 slides, and put one slide where we can start an open discussion together specifically about Ukraine. And to summarize in 3 slides all what happened around MHPSS globally, I'm going to use the WHO's three main functions: leadership, global goods, and country support. I'm going to share with you some overviews or reflections on how this is happening nowadays on mental health and psychosocial support, with specific focus on multilateral collaborations. So what leadership role WHO is playing in mental health and psychosocial support? WHO is contributing first to estimating the size of the problem. We take a balanced and scientific evidence-based view in documenting and key publication we had in Lancet estimating the WHO projections for mental health needs in conflict settings. WHO does not say that everyone in conflict settings would need mental health treatment, but WHO says that there is a huge need in conflict setting, 1 in 5. Not everyone, but still large enough. Not only one condition. We don't focus in our evidence or our estimates on depression or PTSD only, but on wide range of conditions. So 1 in 5 people would have a mental health condition in conflict settings. Means around 22%. And we published this in Lancet last year and used by many agencies as guidance for what to do in these situations. Mental health and psychosocial support was recognized by all the heads of UN agencies, international NGOs coalition, and head of ICRC and IFRC on 5th of December as a cross-cutting issue. Means that it lies at the same place in humanitarian system with other cross-cutting areas, such as age, such as gender, and such as disability. On 5th of December, it was recognized as cross-cutting, and then in number of key publications that came afterwards during COVID-19, it was even emphasized by many UN agency heads and leaders, and including the Secretary General report on COVID. I'm putting its picture here, the Secretary General report on COVID-19 and mental health, where the Secretary General has highlighted last May how MHPSS should be a cross-cutting and integral component of all governments' response to COVID-19, and how all international organizations working in all sectors, not only health, but also education, social sectors, camp management and coordination, nutrition, water and sanitation, need to include part of their budgets and part of their activities covering mental health and psychosocial support. Director General of WHO, Dr. Tedros, has also a couple of months ago sent a formal email to all regional directors, which was very much welcomed by Regional Director of European region, to make mental health and psychosocial support a cross-cutting also, not across sectors, but also within the health sector itself. To make mental health and psychosocial support part of also mandatory training for all WHO humanitarian officers in all emergencies, and to have in all WHO country offices capacity staff responding to mental health and psychosocial support. In COVID-19 incident management system, for example, at the Department of Mental Health, we are collaborating with wide range of pillars. For example, the clinical management pillar of COVID-19 and case management. We collaborate with colleagues who work on logistics and operation because of duty of care and staff support. We collaborate with risk communication and community engagement because we need to include a stress scoping component in this. Even we collaborate with colleagues working on points of entry because, for example, in the seafarers, in the ships without passengers, all the staff working there need mental health at workplace as well. So we collaborate with wide range of persons. The monitoring and evaluation, MHPSS need to be there. So we collaborate really not only across sector, but within the health sector itself, with all the vulnerable groups, colleagues working on maternal and child care. Whenever they do a guideline, we need to make mental health and psychosocial support part of it. The work on infectious disease such as HIV during COVID time. The work on older adults, we need to make sure that mental health and psychosocial support is part of it. So really it's not only cross-cutting across sector, but cross-cutting within each and every single sector, and health is a strong example. And before we're doing it as part of advocacy, but now we have mandate from our senior management to do it. The Global Humanitarian Response Plan of COVID, for the first time, we have a historical moment where a humanitarian response plan prioritizing MHPSS. So OCHA in this important plan has put number of countries as priority, and one of the priority countries is in fact Ukraine. And in this Global Humanitarian Response Plan, for the first time, we have an indicator, a global indicator for MHPSS. And the global indicator focus on establishing country-level MHPSS technical working group. And we can safely check the box when we look at Ukraine here. But the Global Humanitarian Response Plan also asked all country-level response plan to prioritize MHPSS for all vulnerable groups and to prioritize MHPSS while dealing with all the strategic priorities in countries. At global level, WHO is co-chairing together with the Red Cross, with I4C, is co-chairing the Interagency Standing Committee Reference Group, which is a coalition of 58 organizations representing all United Nations agencies, international NGOs, and Red Cross and Red Crescent Society, which has been very active in the response. In fact, there is a tradition within the reference group to do calls, regular calls, whenever there is a new emergency. So in fact, the group started to do calls since the outbreak was only in Wuhan, and start to discuss. That's why we were ready at the very early stage of the response and release the guidelines. MHPSS guidelines was one of the very first guidelines released by the interagency humanitarian system in general, because the group is very cohesive and agencies work together as one family. And we see this reflected in the field in many countries as well. One of them is indefinitely Ukraine. One of the key functions of leadership is reaching out and learning what countries are doing. And we had a call together with London School of Hygiene and Tropical Medicine for countries to document best practices on continuity of mental, neurological, and substance use care. And more than 50 countries has responded, and we have 100 stories, including video interviews with frontline responders from different countries in Europe and in other regions as well. So I encourage you, if you haven't seen these videos or stories, to please have a look. There are really a lot of pearls of wisdom that we can all learn from what colleagues are doing in countries, new innovative methods. And then normative tools. COVID-19, as I said, agencies worked together very early, and it was great to have early some of the recommended activities through the interim briefing note, available in numerous languages now. But most of our materials range from first guidance to agencies and guidance to governments. And this applies to the interim briefing note and the operational consideration documents. And this does not focus only on health sector. Colleagues working in education or protection or long-term facilities, many will find in these documents material which can benefit them. Again, many of them are available in many languages, and thanks to Ukraine office for and Ukraine teams for the leadership in translating this so quickly. So first group of material is for agencies and governments, and one of these also is the Essential Health Services Guide, which have a mental, neurological, and substance use section. Again, telling countries what is the minimum service that can be maintained during this time. Second group of materials we released are materials for COVID-19 responders, ranging from materials for clinical worker. So COVID-19 does not only affect the respiratory system. COVID-19 have also neurological and mental manifestations. And all clinicians need to learn what are these manifestations and how to deal with them. In fact, the WHO COVID-19 clinical management May update is telling us that all COVID-19 clinicians need to be trained on a set of basic psychosocial skills. That's clinical recommendation from WHO, that basic psychosocial skills are an integral clinical skill for all COVID-19 clinicians. So in fact, WHO, together with IASC partner, released a guide on basic psychosocial skills. So, and this guide is being translated to Ukrainian, just released around 8 or 9 days ago. The basic psychosocial skills guide is released not only for health workers, but for people who work on essential service, for police officers, for grocery store worker, for funeral workers. So really a guide for food distribution officer, for anyone, how to integrate day to day while you're communicating with people, how to integrate a set of skill to improve the well-being of the people you're dealing with. It's very simple and designed with more focus on images than text. And then the other set of guide is for the public, giving the public advice, starting from developing a set of mental health and psychosocial messages that can be disseminated through social media and again translated and used widely, creatively in Ukraine, to guidance for health workers like stress management guides. Stress management guide follows a bibliotherapy model where you can read a book and there is enough evidence through randomized controlled trial that this book can actually treat people, can have an equal effectiveness of having psychotherapy session. It's a breakthrough. It's groundbreaking that not only task sharing, but there are things that you can do alone that can help you not only in coping, but can help in treatment. So this book is also either being translated or also available. I think it's available already in Ukrainian, not only as a book, but also in social media messages. And finally, the very famous example of the children book. And I think there are many factors that we can learn from that make this My Hero Is You very successful. It's disseminated globally, and as R has said, Ukraine was one of the first countries that translated it. But the amazing news that it's now available in 110 languages, considered one of the top 20 most translated books ever. So what's in this book? Why all the countries are interested? We hear about even indigenous population far away in islands, in Africa, in Asia, translating the book. Why? What's there? I think the answer is that because we asked children and parents before we design it. It follow what we call human-centered design. So we design it with children. And while we design it, we consult with children, 2,200 children, aged 6 and 11, boys and girls, including from Ukraine, were consulted from 100 countries while this book was designed. So we did not just write the story. We write the story through asking the kids how they are coping and what is stressing them. In fact, My Hero Is You is having soon other parts. So Action for Heroes is a caregiver guide being developed now, which give guidance to teachers, parents on specific activities to do. And also My Hero Part 2 is going to be released with the next school year. And you will see Sarah, who is featured in the book, going back to school and learning new skills, how to cope with her new friends. So there are teams now working on other parts of this important tool. And all this did not happen because of COVID only. All this was building on years and even decades of experience of developing tools. MHGAP Humanitarian Intervention Guide, which is available in Ukrainian and has been used, and Ukraine has been hosting a number of global trainings and leading coordination groups also in its use, is still very valid. And in combination with the clinical management of COVID, remain a very effective tool. And using operational consideration document, you can adapt it and start using it to support COVID and also the humanitarian response. It's impossible to summarize all what WHO is doing for country support in one slide, but slides can tell us snapshots and some nice stories. So let's start with the first lady. Who is this lady? This is a picture from Addis Ababa airport. So what WHO is doing globally now is starting a global surge mechanism. If MHPSS technical working group needs surge support, rapid deployment for MHPSS coordinator or capacity building, rapid deployment, and through actually this mechanism, you can get trainers to support, and this is a picture of a colleague from Kenya was deployed to Ethiopia to support MHPSS group supporting displaced population. But this request does not come from agencies. They need to come for interagency support. Second picture is from Philippines. Philippines have MHPSS technical working group led by WHO together with the Ministry of Health, but they did a very nice idea. They have in every health facility responding to COVID an MHPSS focal point. And this is a picture from the WHO office hosting a meeting for MHPSS focal points at different health facilities. They don't only meet with them virtually, but they go to the hospital sometimes and do capacity building initiatives there through a network of colleagues who are supporting. Third picture is from Ukraine, from a very good training and initiative that Alisa has shared with me, building the capacity of nurses on mental health and psychosocial support. Fourth picture is from WHO in Turkey, having a cross-border operation through an MHPSS helpline to support people in Idlib, in northwest of Syria, where no one can have access to, but this gentleman is trained to provide MHPSS support through helpline. And this fifth picture here is from a mobile team from WHO in Syria, and this team is trained on MHGAP before the crisis, but now outpatient facilities are not available in Aleppo, has been shut down, but this team go to the most vulnerable cases, providing medication at home and providing psychosocial support. People are using the global goods you see and adapting them, and the picture here below is for a creative idea that a colleague had in Greece. They took the storybook and combined with a newspaper in Greece, and while there was a complete lockdown, they disseminated the book from home to home through attaching it to paper and disseminated in Greek. This picture here, the one on the second line, which come from for Native Indian Americans, is in fact done by Johns Hopkins University. They took the children book and found that they need to do some cultural adaptation through a workshop with the Native Indian Americans in Turtle Island in USA. So they adapted it in a scientific method by the Department of Native Indian American Studies in Johns Hopkins, and you see a Native Indian American version used with a vulnerable population in USA in Turtle Islands. And then the picture here in Arabic language is actually in Gaza, where the Norwegian Refugee Council make an announcement for a competition for all children to say how they were heroes during the COVID-19 time. And then they prepared a radio series for children to listen for actors. And the actors were among the children themselves on My Hero Is You and coping strategies, but through the radio. The same idea actually did not happen only in Gaza. The same idea happened by a very creative producer in Germany in a high quality theater play based on My Hero Is You. The picture that you may have difficulty seeing, the one which look very pale here, is actually Braille language. So Zimbabwean blind mothers took some of the material and adapted it in Braille language so that children with blindness and other mothers with blindness can take the material and use it for mental health and psychosocial coping. We can do all these materials, but we should not miss group like children with blindness, children with hearing or speaking problems, which are actually being done. There is a sign language of some of these materials, and there is also audio materials available this also for children with visual problems. And last slide, I'm putting the picture from Sri Lanka, a country that had years and years of civil war, had very limited mental health services, and then had a tsunami. The picture is showing gradually, the more darker, the more community mental health services are available in different parts of Sri Lanka. The last picture is from 2018, showing how a country during 8 years was able to move from having the very pale color is no community-based mental health services until 2018, the country was able to achieve more than 80% coverage of community-based mental health services. It's building back better. using the emergency as an opportunity to build back sustainable mental health care system. Some of you may have heard about the multilateral plan led by UNDP called the UN Socio-Economic Framework for COVID-19. It's one of the multilateral plans, such as the SPRP from WHO and the GHRP led by OCHA, UNDP, which most UN agencies contribute to. So from the 5 strategic priorities of the UN Socio-Economic Framework, I put 3 priorities. And I'm putting here some examples how this is happening before COVID, because Ukraine was doing very good rebuilding for mental health system before COVID. And Ukraine was doing emergency response in the East. And at the same time, there is now the COVID response. So first point in the UN socio-economic framework is protecting health services and system. Ukraine is introducing community-based mental health services at PHC through the MHGAP coordination framework you are currently doing and need to continue doing because it's part of COVID response, part of the emergency response, and part of rebuilding the system. But you are not only focusing on health sector, you're supporting the social sector because you're putting the financial plan for the institutionalization of mental health care and social facilities. And finally, the social cohesion and community resilience. You are supporting the most vulnerable population in the east of the country through a wide range of mechanisms, including the mobile teams. These activities need to continue and need even to be scaled up more during COVID-19. Thank you.
Thank you very much, Fahmi. Colleagues, now we have time for questions, and we have, as usually, two options. We can type in the chat, but probably it's better to ask Fahmi verbally. I know that almost all of you know Fahmi, so don't be silent and please ask questions directly. And while you're thinking, I would like just to thank you, Fahmi, for contribution to the development of all those great tools. And we indeed have at country level a huge range of resources covering almost all needs here. And we are in the process of translating, adapting, etc. And now it's really good like time, and we now moving to, with this launch of this workshop, we are moving to question how to implement all those in practice at country level. So it's really a lot of work to do, and thanks again, Fahmi. Colleagues, please ask your questions now or type in chat.
If I'm not going to be asked questions, let me ask colleagues questions. A capacity building of nurses. And this is maybe a question for you, Alisa.
Thanks, Fahmi. I would explain in more detail. So in the training that Fahmi shared picture with us, it was actually were not only nurses but also primary healthcare doctors, and during that moment we actually provided training to healthcare workers in primary healthcare facility on basics of MHPSS. And the purpose was to build capacity of healthcare workers to on stress management, on basic stress management, to help themselves to cope with stress and to take care about people in stress related to COVID. And also first session was to help health service managers to organize services at facility level. So we are talking about the package that we recently developed jointly with Public Health Center, and that Jarna mentioned in the beginning.
I see a colleague asking about tools for assessment and also tools for supervision. I'm putting here the MHGAP operations manual, which include in its annex number of tools that can be used for supervision as well as evaluation of different MHGAP interventions. And I encourage the colleague to use this tool. Colleagues, can we can we hear from you? What challenges are facing you in continuity of services? I know many organizations are doing excellent work in Ukraine. What challenges you facing now to continue services, and how creatively you are able to adapt? Can we hear from MDM, IMC, UNICEF, or UNHCR who are online?
Olga, please go ahead. You raised your hand.
Let me maybe remind everyone. And we implementing partner of UNHCR, and we on line and 0 to 20. Because we only partly transformed our services to line to phone services, but have access to mobile connection, and I can say it was challenging for us to understand how to make it, how not to transfer COVID to villages near contact line where no ambulance arrives and there are only 30 people, mostly elderly, who live there. So there were many measures how to stop really not to transmit COVID by our staff, and can say 5% of videos and still 35% of in-person consultations, and now we have 70% of in-person consultations. So people we see now that our main challenge is not just direct provision of our services, but we see that not all our beneficiaries have access to basic emotional support, and it's a problem because of many organizations. So it was not our main goal, and not many organizations provide it online only, and for us it's a question how to provide this support with restricted group meetings without internet. So we can only print some kind of newspaper and distribute. So but we still are in search of how to do and what to do, because we see that that is a gap now.
Very good, Olga. Thank you, and great to see you, Olga, and thanks for the insights. It's interesting to listen to your experience. I'm reading what a colleague from MSF is putting online, that he or she received refusals for receiving the psychological interventions by healthcare workers.
Mm-hmm.
And it's fine. If you receive refusal, you should not push the person to talk. We have enough evidence that interventions that push the people to talk, to speak about traumatic experience or repeat it, that these interventions are harmful, actually increase the incidence of mental health problems. WHO has guidelines against providing debriefing, specifically critical incident stress debriefing. So we don't recommend pushing people to talk if they don't want to talk. It's one of the coping mechanisms, and the evidence we have in these guidelines is that these interventions are not only not useful, but there are some systematic reviews that shows that interventions which push people to talk while they don't want to talk are actually harmful. They may induce harm, and that's why tools such as the basic psychosocial skills or psychological first aid start from the assumption, very different assumption. They start from the assumption of don't push people to talk. and integrate the psychosocial support skills into your day-to-day skills. And the reason why we developed the basic psychosocial skills while we already have a psychological first aid is that we felt psychological first aid in its current form may not fit for COVID-19. That's why we had a chapter on the operational consideration document on how to adapt PFA. But people in quarantine, people who stay in their homes for a month or two, health workers who work every day, it's very difficult to deal with them as you deal with an acute crisis like natural disaster, like a hurricane or a displacement emergency, or a road traffic accident or a big fire. It's not an acute incident. It's something that continue to happen across weeks and months. So that's why we felt there is a need to do something like the basic psychosocial skills, where you integrate the day-to-day skills into people work without pushing anybody to talk. While you listen, while you provide effective communication, while in your body language, you are also providing basic psychosocial skills. The way you look at people, the way your tone speaks is providing basic psychosocial skills and linking people to service. That's very different from pushing people to talk, which is known to be harmful. Regarding the second issue of healthcare worker who shares the coronavirus misses and even believes that it doesn't exist, the best way is to combat misses and wrong information is to share the right one proactively, not only negatively. There is an excellent website of the Mythbuster by WHO, and colleagues in risk communication effectively do very good way of tracking rumors. This is a function of risk communication, to track rumors and to give correct scientific responses to this. Link people to correct information. We know that this actually contributes to psychosocial well-being. Sharing correct information and sharing the right trustful and trustable resources and scientific resources is good for psychosocial well-being, because people can also feel more control and feel the ability also in taking informed decision about their own life and about the life of loved ones.
Thanks, Fahmi. I also wanted to share one example. I'm not sure that we answered all the questions ourselves, but at least there are initiatives made by partners to proceed, and I'm going to talk about MHCAP now. So as you all know, and Fahmi, you also know, since you're engaged very much in this initiative, MHCAP in Ukraine, many partners started MHCAP already and now continue with supervision, and like IMC, WHO and SDC funded project Mental Health for Ukraine and others. And the other partners just planning MHCAP capacity building and rollout. And now, as you can imagine, that situation not very like supporting, so situation doesn't support MHCAP trainings, and basically the main challenge is trainings, because supervision, those started supervision already, they continue easily via online. And I would say that even before the COVID pandemic, most agencies provided it online, so via Skype or other programs. So I would not say that COVID affected supervision, but for those who plan trainings, it's quite challenging now. But at the same time, many agencies, like we as a group, as MHCAP group, or I would say subgroup MHCAP, developed interim guidance how to provide MHCAP training. We suggested to make training day a bit shorter and exercise between the modules, and provide this multimedia providers like Zoom, for example, which allow us to split up the whole group to two separate groups, and it allows the trainer to go from one to another and participate like in real life. Of course, it's not ideal situation, but at least this allows to those partners who planned MHCAP just start with it, and then hopefully situation will improve, and then we'll can continue with real trainings. Some of those agencies like SDC funded project and I guess SDC funded project MDM and in WHO we're currently thinking what might be the approach for us, and MSF is also really planning to start trainings, and solutions are different. Some of them decide to go with real groups. I mean, to provide training in face-to-face with very small groups, and others plan to do online trainings. So probably you have like general or some probably specific recommendations on that, because we're really, like I would say, all engaged partners are really interested to keep going with this, and to not stop MHCAP due to COVID. And as you mentioned, that essential health services, including mental health services, should continue even more intensively due to COVID pandemic. Thanks. Over.
Thank you, Alisa, and it's very clear. I see our colleague Natalia from Red Cross want to mention something about the remote psychological first aid adaptation done by the Red Cross. Can we give the floor to Natalia, please?
Good afternoon. Yes, we already done adaptation of the training of the first psychological aid, which was provided by, and we would like to share it and to take some comments from you, because adaptation was to the Ukrainian reality. And our head of office kindly asked me to give you information about this, and to have some conversation after somebody will look and maybe have some comments. Thank you.
Thank you very much, Natalia. And I think Trala want to share something about CETA project?
Yes, hello. I wanted to just mention, I think that the challenges that we have faced in transitioning to online is similar to what other people have experienced. You know, lack of internet connectivity, those kind of issues. However, I wanted to mention that we've done some qualitative interviews with clients and counsellors since they made the transition to online counselling, and people really observed that they experienced many benefits from online, and they were pleasantly surprised by the benefits they were experiencing, both in terms of treatment and convenience of receiving services online. Even though, you know, they also experience technical difficulties. That's all.
Thank you. Very clear. I think COVID has damaged many things, many institutes, many people, and many areas, and one of them is mental health. But one of the benefits, if we can say so, of the COVID-19 crisis is that I think it will give huge advance for the area of remote support in mental health and psychosocial support. What we were seeing as something would never happen, or we were questioning, such as remote training and remote supervision and remote psychotherapy and remote outpatient clinic, became a reality. If you look at the Mental Health Innovation Network and the documents, the documentation that we had from countries and the video interviews, that's what many people are doing. And countries that actually lack access and were creating before COVID some innovative way for remote support. And I'm giving the example for the remote support provided to Syria operations in places like Idlib, which is classically, even before COVID, was inaccessible, were able to function rapidly in this inaccessible area during COVID and scale up the response. I think there is a lot. I mean, the advancement we will have in the remote psychosocial, mental health and psychosocial support after COVID, I think will be remarkable. I see Taras want to say something.
Thank you, Fami. Hello, Fami. Yeah, so IMC now is also modified our services, according to the situation. So we do our best to provide MHPSS response to the population in mostly in Volnovakha rayon, so it's within the 10-kilometer zone across the line of contact. So yeah, we have I think the main challenge is lack of gadgets, and also it's a poor internet connection in villages, not stable internet connection. So but what we do is that we do our best to provide online services. So we created groups of people in these locations who want to participate in our services, for example, as a self-help plus groups or on positive parenting, etc. And also we provide awareness raising activities on COVID-19, so mostly on MHPSS response to the COVID-19 pandemic, based on materials, mostly of WHO materials, of course, So and also we try to individualize the services, so to be adaptive and inclusive. If people, for example, they want to participate, but they don't have access to the internet, so we try to provide individual services via phone, just like mobile phone. So, and I could say that we have a very good feedback from the local population, from beneficiaries. So they really appreciate these services. So I hope that we will continue this approach. For example, we provided set of awareness raising activities for medical staff in PHC, in villages, for example, on stress management techniques, and also on remote PFA, how medical staff can provide remote PFA for patients, for example, like via phone. And also they really appreciate these interventions. So we will be happy to continue. Thank you.
Thank you, Taras. Good work as always, and appreciate seeing you, and my regards to you and other IMC colleagues in Ukraine. Alisa,
thank you for me.
Thank you, Taras. Did we run out of time?
No, I think we have else up to 15 minutes. It's okay.
Okay. Because I see Victor wants to say something.
Okay, but I also see that Lydia raised her hand.
Okay.
Lydia.
Hello, do you hear me?
Yeah, please go ahead. Yeah.
I will try to be short and will not repeat, because yes, we do face the same challenges as other agencies do. But I would love to share the biggest one, which because we are somehow managing this individual support, like via phones, etc. But we have difficulties with capacity building events, and if they are short, like supervision, they are more or less okay. We still manage it in spite of the connections, and we try to use different. We even analyzed different available services. Some work better in very remote locations, but with capacity building, in particular MHCAP or other events which need a lot of role plays, and you need to observe people, it was quite difficult, and therefore analyzing everything, both participants' location, we still decided to do it offline. So if anything will change, we do a brief analysis of epidemiological situation, as well as we have very strict internal rules, like not more than 10 people, 5 square meters per person. So we will see how it will work. But next week I'm going to have offline MHGAP training in Bakhmut. And so what I'm saying, there is still, I don't still see, I really did a lot of work to analyze like different groups through Zooms and come into different groups to see people, how they role play. And we even tested it, but I'm still quite skeptical that it is possible to do like big trainings, which requires a lot of skill practicing by participants. So this is how we choose to act now, and then we will see. So this is, I'm backing up your Lisa's request, like are there any options available? And at the moment, we see this one as the best one. And we have many ideas about what Taras mentioned about the devices. We're even thinking to recording something and then give the device, potentially very simple devices to the people to be able to listen to the recordings. So we have quite a lot of ideas somehow to answer the challenges, but we'll see. So thank you.
Excellent. Thank you, Lydia. Colleagues, I have a suggestion in the remaining 10 minutes or so. Can you very briefly share with us not the challenges this time, but either an achievement or an activity during the COVID-19 MHPSS response that you are very proud of? Very briefly, an activity or an achievement or a project, something that you did in COVID-19 MHPSS response and you're really proud of and want to share with others.
I will be repetitive, but I would mention the training package that we developed on basics of MHPSS for healthcare workers. Over.
Good one, Alisa. And Natalia, the PSS kit, which one? IFRC and ICRC produced many. Which one you are so proud of?
We take we create PSS kits for children and for elderly people. There was some exercises and some things which help with helping to people with their emotional situations, and we give some instructions for it, and it was hundreds of PSS kits was given to our beneficiaries in our regions. Also, we have a Tell Me platform. Now we have a big board through Kyiv, and it is a platform in which everybody can call for psychological support. And this project was just started. And also we organized for our volunteers and for our staff professional psychological support. We have a contract with the institute, and they provide 300 hours of the professional psychological counsel for support our volunteers and our staff. It is for now. Thank you.
Natalia, thank you. And indeed, the activity cards also that you have developed within IFRC is something really to be proud of, as well as the many other activities you mentioned. Very useful tool and unique as well.
Thank you very much.
MSF provided informational PSS presentations in more than 15 medical facilities with more than 360 participants. Indeed, good one to be proud of. I am inviting Adra to talk because you didn't get the chance to talk before. Adra, would you like to tell us why you are very proud of this activity? Adra, I think Adra, okay, Alisa, if she can talk in Ukrainian and you help in translation. Alisa, please, or Oksana?
I will briefly translate what Olga shared. So ADRA has 5 mobile teams, and they provide these services in the zone of 0 to 5 kilometers. And they made a series of trainings for teachers and families, and also disseminated the booklets on how to cope with stress during COVID for adults and children. And what is more, they created 2 cartoons, like animated cartoons on how to cope with COVID-19 in terms of where and how to find the support and the assistance. So they continue to provide online PSS via every available platform like Zoom or Skype or anything available to the beneficiary who needs the counseling.
Very good. Very helpful. Thank you, Oksana. And Oksana and Elisa, I have a suggestion for the MHPSS Technical Working Group in Ukraine. Maybe you are familiar with the resource called the MHPSS.net Toolkit, where they put all the resources developed for COVID MHPSS in one catalog with putting the links. Ukraine is a big country with so many MHPSS actors. I would encourage you to develop something like a catalog for all MHPSS resources developed to Ukraine, because colleagues in ADRA now shared with us about this cartoon films. You may hear about the assessment done with another colleague. You may hear about the PSS toolkit in Ukrainian. So maybe you can have a Ukrainian toolkit for all MHPSS resources developed by different partners. And I think if you make it a nationwide exercise of collecting resources, you will be surprised of how many are already out there. And I think it would be a very useful exercise, developing a catalog of MHPSS Ukrainian resources. I see Trala is talking about technical guidance on transition to providing online MHPSS, updated safety protocol for 70 councils in 8 oblasts, and trained 50 providers, online reporting for home-based work. As Larissa and the Polish Humanitarian Action did not get the chance to speak, I'm inviting Larissa to speak, please.
Polish Humanitarian Action support elderly alone contact line. And when COVID-19 beginning this COVID-19 pandemic, we tune on all our activities to online. We develop a very simple tool for providing online PSS support for our community workers. To learn people how to cope with stress. Also, we develop booklets about some recommendation how to cope with stress. Our curriculum includes information about COVID, about how to save their health. But we have some our beneficiaries who lives without connection, who has problem with hair and cannot receive our support, PSS support by phone. And our employees continue to provide home visits for these beneficiaries. Of course, they use PPE for this. Now, when quarantine measures become lighter, we start provide group activities for 4 centers, which has place outside with distance, with all protective measure. And our elderly are very happy that they can meet again, and they're happy like children.
Larissa, it's great work, and congratulations to you and colleagues in Polish Humanitarian Aid for supporting this group. I think COVID-19 teaches us that we were all not doing enough for older adults in MHPSS. And it's such a very difficult group also to address on MHPSS. So again, one of the positive things we will learn here is that so many actors are just starting to develop material for older, and some of them is the IASC reference group. So similar to the children's story, we're developing graphical materials to be disseminated globally for older adults, including older adults in long-term facilities that I expect will be ready in 4 to 6 weeks from now. I see more and more messages of pride.
Access is continued to be provided to older people, children and adolescents through online, Viber, and other online measures, and also where no phone or internet connection is possible, and mobile PSS brigades are providing PSS. And what I was mentioning in the chat is our information campaign on COVID-19, which started in April, and it's funded by IASC. And it's there is a promo on the importance of social distancing and other measures. And also there is a weekly program which is called Social Distance, and this comes every Thursday. Previously it was at 4 p.m. Now it's at 1 p.m. And it's usually medical experts and psychologists, and a lot of programs were devoted to combating all the fakes. Also, we use the WHO website for this because there are a lot of fakes like ginger or lemon helping against COVID, or like 5G is dangerous, and many others. And also there were a lot of psychologists who provided recommendations on how to deal with panic attacks, with sociophobia, on people who fear exit from the quarantine, also how to live in one apartment with other family members when you have to work from home, and also how to deal with stress and anxiety. And also some practical recommendations were given, like how to deal with stress through body therapy, body psychotherapy, or also techniques of mindfulness. So the Grammatical Radio has a very broad audience of more than 1.5 million, and this program was also broadcast on Ukrainian radio, so it has all Ukrainian broadcasts. So I think these recommendations were helpful overall all over Ukraine. Thank you.
Katarina, thank you. I think it's a great work and very important work indeed. Katarina, allow me, if you give me the permission to share with you one small advice. May I, Katarina?
Yeah, sure.
WHO has advocated for mental health reasons early in the response to stop using the common term, epidemiological term, social distancing. It was all over the news. I'm sharing with you one article from the CNN, but most news agencies have quoted WHO in the press release. We announced we prefer stopping using social distancing. We prepare people to be physically distant, but socially connected. And the risk of using social distancing is that people actually may think that they should be socially distanced, while I know you are doing everything right. What you're doing is actually keeping people socially connected. And social distance is an old epidemiological term that, right, WHO was using at early stage of the response, but WHO has formally stopped using this term for the reasons you were reading this article. So actually, I think if you change the name you are using, it might be a campaign itself in changing the term from social distance and physical distance, but socially connected.
So if I may, the point is that this program title was not not as Best Inventions. This program existed before. It's from Grammatical Radio. So we just, first of all, but actually the motto of this program is called Social Distance. But the point was how to keep safe and psychologically sound during. So it's not meant in this epidemiological sense, but in a different way. But I may suggest so there is no confusion in the future. But they're all aware of all the points that you meant, so it's okay with it. Thank you.
Thank you very much, Katrina, and thanks for the very good work as well. Okay, Oksana, Alisa, any final remarks from your side?
Thank you, colleagues. Thank you, Fami. We are definitely going to take into consideration your suggestion on collecting more comprehensively and continue to collect successful practices from agencies, and we will think what's the best way of doing this and come back to partners with suggestions, and it's definitely a very good idea. And thank you very much, Fami. And this was first introductory part to this series of learning events, followed by Marcio or Sarah. We are now in touch with them, with Oksana, and trying to check who, like, their availability for coming weeks. Then we come back to you all with concrete date and topic. But as mentioned, we are going to, in nearest time, we're going to cover monitoring and evaluation in situation of COVID pandemic, and also program planning, which is very relevant now in terms of changing the modalities of work, and as was requested by you all. So we will come back with more concrete information soon. And thank you again, Fami. Thank you, colleagues, for being very, very active and sharing your great practices. And now we move into our regular MHPSS technical working group meeting. And Fami, I know that you are very busy, and please decide if you wish to stay with us and discuss our very practical thing, or you can leave us as for now.
Ali, thank you. Thank you for organizing this. It's really great pleasure. I would love to stay, but I have to leave because I have another call. But you all shared what you are very proud of, and from my side, I'm very proud with my participation with you today. Keep up the good work as always, and we stay in touch. The next speakers are really good. The selection of the topics show how much really the MHPSS actors is really sophisticated and keen to scale up the system. So so keep up the good work and stay safe.
Thank you, Fami.
Thanks everyone.
Thank you. Bye, Fami.
Bye.